An 18-year-old woman with acute liver failure. Presentation of the case. An 18-year-old woman was in the emergency department of this hospital 11 weeks after the birth of her first child because of acute liver failure. Evolution of the disease. The patient had been well until 1 week before this presentation, when rhinorrhea, sore throat, and cough appears. Over the next 3 days, abdominal discomfort, nausea, vomiting, diarrhea, and vaginal bleeding developed. The patient also noted progressive yellowing of her skin and eyes. The abdomen was distended and tenderness was present in the right lower quadrant. Acute liver failure differential diagnosis. Acute liver failure in adults is characterized by a sudden loss of hepatic function without evidence of pre-existing liver disease. Criteria for the diagnosis include the presence of coagulopathy, hepatic encephalopathy, and an illness of less than 24 weeks duration.
In Liver Talk today, we're going to talk about acute liver failure. Acute liver failure is basically liver attack, quite like a heart attack or a brain stroke. It affects the person just suddenly over a matter of few days. A person who's perfectly well and healthy before is suddenly affected by acute liver failure, which is usually due to hepatitis E or hepatitis A or hepatitis B in adults, and a disease called Wilson's disease, which is basically copper metabolism gone wrong because of an enzyme deficiency in children. And what happens in this is that the person suddenly gets deep jaundice, starts to develop coagulopathy, which basically means bleeding tendency, and slowly goes into a confusional and drowsy state, and then goes on to pre-coma and coma. Now, such a person obviously needs to be referred urgently and cared for in a liver service or an advanced liver disease center. Some of these patients can actually be treated medically and they get well over a matter of few days to weeks, but a large number of them need an emergency liver transplant to cure them. Otherwise, they would lose their life. At Medanta Liver Institute, we have a special rapid response liver failure team where we receive calls from patients' families, referring physicians and hospitals from all over India and even abroad, and transport these patients by air or road ambulance as appropriate to our liver service, where they can be cared for in a specialized liver ICU with medical treatment, or we proceed for an emergency liver transplant if necessary.
Wilson disease. This disease is also known as hepatolenticular degeneration. Is an autosomal recessive disease characterized by impaired copper metabolism due to deficit ATPase.
One essential mineral that our body needs to get through the diet is copper, and typically we take in about 1 to 2 milligrams per day from the food we eat. Things like whole grains, beans, nuts, and potatoes. But really our body only needs about 0.75 milligrams per day. So that extra copper is excreted. About 90% of the excess copper is excreted into the bile, where it eventually ends up as fecal copper, and the other 10% is excreted in the urine. In Wilson's disease, there's this genetic defect that results in the excess copper being kept in the body and deposited in various tissues, where it's definitely not supposed to be. And just like iron, free copper can react with hydrogen peroxide in the body to form the hydroxyl radical, a reactive oxygen species that's pretty good at damaging tissue. So over time, those tissues are seriously damaged by free radical generation. Now, your liver cells, or your hepatocytes, play a really important role in helping the body get rid of excess copper. So usually the copper from the diet is absorbed into the stomach and small intestine via enterocytes, and passed off into the portal vein to the liver. Once it's in the liver, it's sent to a special transport protein called ATP7B, which has a couple super important jobs. The first job is that it binds copper to apoceruloplasmin, which is the major copper-carrying protein in the blood and is responsible for carrying about 95% of the copper in the blood. After it binds copper, it's then just called ceruloplasmin, and this guy can haul 6 molecules of copper at once. ATP7B's other job is to gather up the rest of the copper into vesicles to be exocytosed into the bile caniculi, where it goes into the bile and is eventually excreted. With Wilson's disease, there's this autosomal recessive defect in the ATP7B transport protein. As you could probably guess, that means that it can't incorporate the copper into ceruloplasmin or excrete it into the bile. Since it's not doing either of these things anymore, the copper builds up inside the hepatocyte and starts to produce free radicals. Eventually, all this built-up copper and free radical damage injures or destroys the hepatocyte, causing free copper to spill out into the interstitial space, and from there it can access the blood supply. Once it's in the blood supply, it's circulated to and deposited in other tissues, where it also causes free radical damage over time. One organ in particular is the brain, and for this reason Wilson's disease can have serious neurological symptoms and complications. Depending on where it deposits, it can cause different disorders. If it deposits in the basal ganglia, it can cause a movement disorder that's a lot like Parkinsonism. If it gets to the cerebral cortex, it can be toxic to neurons, which can lead to neuronal cell death and dementia. One place that it can also deposit that can be sort of helpful for diagnosis is in the Descemet's membrane of the cornea, which is this membrane between the stroma and the endothelial layer of the cornea. So you'll look for something called Kaiser-Fleischer rings, which are visible copper deposits in this membrane of the cornea. Since it starts in the liver, though, liver damage is usually seen first, right? And it often progresses from acute hepatitis to cirrhosis and liver failure, and symptoms usually present in late childhood. Typically, when you look at someone's blood with Wilson's disease, you'll note a couple pretty key things. One is that there will be an overall decreased level of ceruloplasmin in the blood. Because remember that you need apoceruloplasmin to bind to copper for it to be called ceruloplasmin. So without ATP7B binding copper to apoceruloplasmin, all you have is this apoceruloplasmin, which is relatively unstable and doesn't last very long in the plasma. And this can be important for diagnosing Wilson's disease early on. Another key feature to note, though, as hepatocytes are damaged and release free or unbound copper, there'll be increased levels of free copper in the blood, right? Which will also lead to increased free copper in the urine. Other common complications from deposited copper in other tissues include an enlarged liver and spleen, hepatosplenomegaly, renal disease due to damage to the proximal tubules of the kidney, and hemolytic anemia due to the direct damage that circulating free copper causes to red blood cells. As far as treatments go, penicillamine will usually be used for Wilson's disease. Penicillamine is this alpha amino acid metabolite of penicillin, but it doesn't share the same antibiotic properties as penicillin. Instead, though, it's a copper chelating agent, meaning it binds to free copper in the serum and makes it easier to excrete. Also, though, patients can be given zinc or ammonium tetrathiomolybdate, both which reduce copper reabsorption in the urine and therefore increase the amount of copper that's ultimately excreted in the urine. Finally, if the liver's been damaged to the point of cirrhosis and liver failure, a liver transplant might be needed.
Clinical diagnosis: fulminant hepatic failure due to Wilson disease. Management and follow-up. This patient received a good quality liver donated from a deceased 23-year-old man who had been declared brain dead because of penetrating head trauma and hemorrhagic shock. She received maintenance therapy with a triple immunosuppression regimen and was discharged home one day on day 9 after transplantation.